and welcome to our vertical integration for this morning, Gender Diversity in General Practice with the very dynamic Dr. Gordon Lau. Before we go any further, I'd like to acknowledge the traditional custodians of the land that we're meeting on today and pay respect to elders past, present and emerging. I'm coming to you from Enewan land in the Northern Tablelands. Today's session is being recorded and we will upload it to our vertical integration website, which I do send out a link every time I send out an invite. So if you have colleagues that haven't come, send them the link and they can find out all the fun that they've been missing out on. That would be great. Don't forget to type in any questions that you might have into the chat box. And at the end of the session, if you can fill out the Slido evaluation, I'll put the link in the chat box. That would be fantastic. There's only one learning outcome. It's very quick and easy to fill out. But it also ensures that we're ticking all the boxes for RACGP. And if you get to 4 sessions in this last 6 months of this year, you're entitled to 40 points, which is fantastic. I didn't ask Georgia or Chris, who's facilitating the Q&A today?
Yep, I'm happy to.
All right, fantastic.
Louise to help me as well, our medical student. Let's throw her in.
Absolutely.
That sounds great.
So feel free to write in the chat group, and I might interrupt you occasionally, Gordon, to ask.
Of course, there will be spots as well too where we're asking and checking as well too. So yeah, that'd be just fine.
All right, well, we might get started. Thanks, Gordon.
Sure. No problems at all. Thank you so much. So welcome everyone to our presentation today on gender diversity in general practice. So my name is Gordon, for those who haven't met me before, and I identify as a cisgendered male who prefers the he, him pronouns. And part of the reason why we're doing this presentation today is because today is actually World Pronouns Day. So I thought it'd be a very fitting day for this topic and how important it is in our everyday life now as doctors in the country. So let's dive into it. Before we do begin, I would like to make a quick acknowledgement of country first. And I would like to acknowledge the traditional custodians of the lands that we are logging in from today. I'm currently on Darkinjung land, and I pay my respects to elders past, present and emerging as well too. This includes, of course, Aboriginal and Torres Strait Islander people who identify as gender diverse, people of all ages, people with disabilities, and as well as people who come from a culturally and linguistically diverse background. Because I think it's really important for us to all be very inclusive, especially when we talk about this topic today as well too. Oh, my mouse here is good. So today's outline, we're going to be doing a few different things today. So I got lots to cover, and I'm hoping to actually give you a bit of a taster about the importance of looking at this topic in our everyday life as GPs. Because often as well too, if we don't ask, we wouldn't actually realize that some of our patients themselves may be identifying as a member of the LGBTIQA+ kind of community. So before we actually go in there though, I would also like to acknowledge the fact that this is a sorry, I acknowledge this is a sensitive topic. So apologies in advance if we do trigger any negative emotions or distress in any way, because it's a very tricky topic that we may actually evoke some strong emotions as well too. But the fact that you are all here today is awesome because it shows me that you're keen to learn more and to make a difference in the lives of gender diverse people around you that you care about. So why all the fuss, I think you might say, because there has been a big rise recently about the importance of inclusion in the community, and it is because of this simple fact. Down here you can see that 11 in 100 people identify as being in the gender diverse community. That's 11% of people in the community, the same number as those who actually are left-handed. There also are significant portions of gender diverse people who report hiding their sexuality or gender identity at work, which accounts for, say, 9%, in the social or community event settings, as well as hiding the identity when they are accessing health services, so to actually escape any potential discrimination. So that's why it's important for us to actually be more aware of this so we can actually look after the whole person in that way. Sadly, verbal homophobic abuse have been experienced by about 60% of LGBTIQA plus individuals, and 20% have also experienced physical abuse as well too. It is important to recognize that that in this group here, we do have some very kind of troubling stats, which unfortunately do depict what is still happening in the community to this day, despite the actual increased understanding and also acceptance of this community in our greater community as a whole. So that's the reason why it's important for us to be aware and to be able to actually help with our acceptance, understanding, and build that stronger link with this very vulnerable population as well. So before we begin our talk today, I think it's very important for us to first address stigma. So I want you all to take a moment there to reflect. And I want you to actually ask yourself, what are your cultural or family views about people who identify as being gender diverse? Also, as well too, what are your community's views about those who identify as gender diverse, as in your immediate community right now? What are your own thoughts about those who identify as being gender diverse? And finally, as well too, how do you feel when you actually have a patient who identifies as gender diverse in your room there, in your clinic? Do you get worried or scared? Because given all the statistics that we saw in the previous slide there, I think the actual the bridge between where we are now to greater understanding it still needs to be achieved, and there is a divide there between the greater community who identify as being straight as compared to those who actually identify as being on the LGBTIQA plus spectrum. How can we fight the stigma? So I love this little diagram here. And yes, there are little fingers, little faces on them, and little thought bubbles and speech bubbles. And I love this picture because it reminds me of something that my grandma used to say. If you hold your hand up in front of you, okay, you can do this for me if you want to. Okay, if you hold your hand up in front of you right now and look at your hand closely, there are no two fingers on each hand that is the same. But you don't judge them for being different because they all work together and each have a role to play. So why would you judge others who appears to be different to you? So that's the one of the basic kind of things that we can do to actually help to fight the stigma, to actually help to actually improve the ability of people around us seeking help and also knowing that they are going to be safe and not going to be judged. So in order to actually help to fight the stigma, we can actually help to educate ourselves better, be polite and listen compassionately, and engage with the person as well too with compassion. And when you are able to actually find out more about things that are important to them in their community as well, and you can also do some further research yourself, you can then share that information from reputable sources to help you in the process of fighting the stigma and tearing down those walls. So let's have a quick little listen to these videos here to understand what does it actually mean to be a person on the LGBTIQA plus spectrum, because I think that's really important, but also as well too to understand the importance of pronouns, given today is World Pronouns Day. So there you go. So you can see now how there are different letters in the LGBTIQA plus acronym and what they all mean. Let's now look at our pronouns. Why are they important as well too? So there you have it. So I hope that actually answers the question, why are pronouns important? Because if you do misgender a gender diverse person, it actually reinforces that they are not accepted by the greater community. And this can therefore create a mental health injury that can lead to suicidal thoughts and also attempts. And I have seen this as well too in my role as a GP at Headspace many times before. So I do apologize, I am a bit biased there, showing some Headspace videos there, but I thought they were really good little snapshots about why this actually is such an important topic, especially for today being our World Pronouns Day. There we go. So there you have it. So some important terminology. We've gone through the whole acronym of the LGBTIQA+, and you can see here that the distribution of people who identify in that way in our own community here in Australia. You can see here as well too that there are different flags for all different groups in there being represented by the acronym as well. But if you were to actually see what is the current actual flag that we use for the actual big flag for inclusion, we then actually have this as a combination here, and is now currently known as the progressive pride flag, because it combines all the different flags together into a single flag to help to actually be there to represent all people who identify as LGBTIQA+. So in healthcare side of things wise, what can we do as doctors to help to look after our patients better? I can show you here, this is the Rainbow Tick Standards, and this is actually by a group down in Victoria, and they actually have a really good manual, very easy to read, and it helps you go through in a checklist style about the different areas they think are important to help to build that inclusion. And that's a really good way to start. You can see here as well too, there's a little sticker here called the Welcome Here sticker, and that's something that's been produced by the ACON group, and you can often find that for our LGBTIQA plus person-friendly venues. And to actually be accredited in that purpose, you need to actually have a reaccreditation process periodically to make sure you still continue to meet the actual requirements for that purpose. So here's some suggestions. So in the waiting room, for example, having appropriate signage can be helpful. For example, having rainbow hearts around, having a welcome here sticker like below, as I showed before, or having unisex bathrooms as well too. So for a person can actually feel comfortable going to whichever bathroom they want to go into, can be really simple things you can do. Having in the reception area there, having friendly staff to actually make the patient feel welcome. That can actually be a very simple first step. And welcome side of things wise includes your paperwork you use as well too, as your normal process of welcoming a person to your practice and getting their details. Having preferred pronouns, preferred name, because that may be different to their Medicare card name, can be really handy as well. Having gender options there for male, female, or other, having a space for them to then fill in what the other is, can also be a very easy change you can make to your paperwork. In the clinical encounter, having gender neutral language, for example, talking about their partner in place of a boyfriend or girlfriend can be handy. But also too, in the referrals as well too, that's where it's really important. Having your actual including your preferred name for the person, if it doesn't match a legal name, makes a massive difference, especially for the specialist referring the person to. Therefore, they don't make the same mistake of actually calling them by their legal name on their Medicare card, where it may not be the preferred name in that way. So why offer gender inclusive healthcare? Well, as part of the private live study in 2019, 39% of LGBTIQA plus people rated their health as being fair or poor, and 14% compared to 14.7% of the general population. Also, as well too, when you're looking at the actual community as a whole, there is actually a much greater increase in the actual level of depression, anxiety, as well as suicidality as well too. Substance use, is definitely more higher, as well as STIs and also incidents of abuse of any sort, including your actual physical abuse, family and intimate partner abuse as well too. They also have a reduced attendance to general practice and primary care in general, and also have a decreased uptake in screening practices, because in some situations that may be actually a touchy topic for them. Hence the reason why it's important for us to be more aware of the importance of offering inclusive healthcare. So how are we going in the present moment for questions? Any questions in the questions field? Because if not, I was going to dive into our next section.
Gordon, but I was just talking to Louisa that the medical software is a lot more gender friendly, and we can write down pronouns.
Absolutely.
And if they haven't changed their Medicare officially yet, we'll put their preferred name in inverted commas. And I must say our staff are really good here as well with that. So, yeah.
Which I think is lovely. And again, that's only been a recent change at the start of the year on best practice. So I think it's definitely a move in the right direction there in that way. So mental health side of things wise, these are some of the simple stats that we can look at as well too. So comparing your top row there for LGBTIQA plus persons compared to non-LGBTIQA plus persons, we can see that there's actually a big divide between how many of the community that was sampled actually felt worthwhile, how many of them actually experienced psychological distress, how many of them actually have depression or anxiety, and how many of them actually experience family violence. So you can see there that every single statistic there, people who are in the LGBTIQA plus group do identify as having worse outcomes. Also, as well too, on a national LGBTIQ+ survey, they found that 30.3% of suicidal thought, 30.3% of them had suicidal thoughts over their lifetime, compared to 5.2% in the non-LGBTIQ+ persons over the last 12 months. And risk factors themselves include lack of family acceptance, and also history of physical and sexual abuse, refugees and asylum seekers, and also those factors themselves do compound severity depending on other factors coming together as a perfect storm. Looking at more statistics there as well too, this is looking at young people in the community, and you can see that that LGBTIQA+ youth are 2.5 times more likely to have been diagnosed or treated for a mental health condition in the last 12 months. And that suicidality is increased, suicidal ideation, as well as self-harm are all increased. In regards to our depression, anxiety, and psychological stress, all those factors are definitely much greater represented in this group than your actual non-LGBTIQ+ people. So what are the barriers then to seeking help? Why do they actually continue to have troubles accessing our health service in the community, even though we think that we probably are doing a lot of good things right now to help to be more inclusive? And that's because there may be a lack of awareness of services and supports. There may be a lack of readiness to seek help because or perceived need for help. So that's often part of our education process that we actually may be lacking in the community, or we're just not targeting the right people in the right way. fear of discrimination or lack of understanding in the healthcare settings. Unfortunately, I have heard many situations where gender diverse persons have come to us at Headspace saying that they felt quite stigmatized or actually deterrent against due to different comments made by staff, be it actually clinical staff or non-clinical staff, and that actually made them feel really uncomfortable. And that can definitely be a big reason why they would not want to go back. Because let's face it, if you and I felt uncomfortable in a situation, why would we want to put ourselves in that situation again willingly? Most of us won't. Also, lack of choice sometimes can be another problem as well. Homelessness, unfortunately, is higher, as well as unstable housing. Risk of that is also higher as well too in people who identify as being gender diverse. Poverty, lack of availability of public housing as well too, and also low cost support as well too. Lack of access to that can actually be a barrier. And I mentioned before already, our negative experiences in healthcare, unfortunately, can be actually a big kind of barrier for the gender diverse persons. So what can we do then? So what we can do as clinicians ourselves is to actually help them build resilience. That includes helping to improve their social connectedness, helping to actually improve their sense of self, and self-care and self-advocacy are very important aspects there that we can actually help to build. But also to helping the person engage in LGBTIQA plus inclusive professional help. There are different clinicians in the community who actually do identify themselves as being LGBTIQA plus friendly persons, and there actually are lists around, so you can find them on different platforms. Like for example, for those students who are going to Newcastle University, they have it on their the Pride notice board. They actually have websites like the Newcastle Pride website there. They got clinicians listed in there who actually both in the medical side of things, or psychologists in there as well too. But also too, other places like TransHub, for example, you will actually find a list of clinicians there, and that actually goes on. I think they actually have about 80 plus different clinicians there at the moment who actually have identified themselves as being LGBTIQA plus friendly people who people can talk to about their transitions and other kind of gender diverse kind of needs. So definitely a helpful way to actually help to direct people to those resources to help them find a person who may be actually more able to meet their needs in a non-discriminatory way. But also too, don't forget CHIMES. And that's why I got a diagram on the side here to remind me to talk about CHIMES today. CHIMES itself is actually and it's an acronym I actually learned last year from the from presentations I did with the Australian and New Zealand College of Psychiatry. And in there, CHIMES stands for a few different important elements. It stands for community, helping a person build a community, building a tribe, helps to create a sense of belonging, give them a sense of hope, to actually help to give them their motivation to keep on moving towards the future and be more future driven, to actually help them actually battle through different obstacles in their path. Identity is really important, because if you are actually able to celebrate your identity, you will actually be able to actually increase your sense of self-worth. Motivation / meaning is the M in CHIMES, and that helps to keep you going, of course. E is for empowerment, to actually help to actually give you that motivation again to actually look further beyond the actual obstacles in our path or other kind of tricky situations we've been in, to help us find a better future for ourselves, and also to reach out for support, which is the S in CHIMES. That quick little acronym of CHIMES can be used for so many different areas. And for those of you who have been to my presentation before, talking about our substance use, talking about gambling, talking about any other mental health conditions, you can use the same kind of acronym there to help you out to look at a very holistic plan for your patient. So what can I do to actually help me to make a better sense of my sexual identity? This is a quick little diagram there from the Kids Helpline. Yes, I know it's more youth-friendly, but the same ideas can be used for persons of all ages. So I do encourage you to actually look at those key elements in there to help your patient out if they are having troubles in this area. Any questions? Oh, sorry, Chris, I think you were just looking at it, weren't you? there are no questions, I'll keep on moving then. So let's dive into our next section. So yeah, you guys are all very quiet today. All right, guys, preventative care. I think that's one of the biggest things that we do as GPs here in the community. So therefore, okay, let's dive into that a little bit more and see how we are going on this realm here. Okay, so health priorities, okay, of course, is important for us to understand first, because if we don't understand what the priorities are, how will we know what to treat, right? So therefore, okay, this is a quick little diagram here. Here's a map of Australia, and also based on the most recent data, how many people in that community, in that state or territory, identify as being in the LGBTIQA+ community. And you can see there that we, on average, we average about 2.5 to 3.5% of the population in each and every state, with the exception being, of course, the ACT, where 5.1% identify as being in the LGBTIQA+ family. So the thing though is that, so in that group there, what do we actually do? At the end of the day, of course, all people, they are still people, and therefore all people themselves in Australia will actually we can get some good advice from our Red Book to help to go through our core kind of concepts about screening and prevention in general practice. So therefore, it's been advocated for us to actually think about it in this way. For all people who identify as being LGBTIQA+, we will always like to think about our contraception, fertility, and pregnancy. Think about our sexual health, STI prevention, smoking, alcohol, and other drug use. Cancer screening as well too, as per the Red Book, but also to think about our vaccinations. Nothing special there, right? But if we were to then look at the actual subgroups as well too, if we're looking at lesbian and bi women as well too, then we also actually need to consider these areas as well too. So therefore, do everything for the general population, plus as well our their screening for abuse and intimate partner violence, because sadly, this actually is a huge part of what happens in this community. Unfortunately, the experience of a lifetime history of sexual abuse in this community sits around 14% for those who actually age between 25 to 30 years. For those who experience intimate partner violence, that accounts to about 25% of all bisexual women. So that's the reason why it's often one of those things that if you don't ask, you don't know, hence the reason why it's so important to find out. And if the person actually does have a partner who may be actually also bisexual as well too, and maybe actually putting them at greater risk of contracting HIV, HIV PrEP or PEP may be also important. Before you freak out about this, I will dive into this in a moment, so don't freak out. Cool. In regards to our STIs for this community as well too, I know we always think about our traditional STIs like chlamydia, gonorrhea, and all that as well too. But in this group as well too, don't forget your actual HPV, your human papilloma virus, as well as your herpes simplex virus, HSV, as well as bacterial vaginosis and Candida are also considered our STIs commonly spread with sexual practices. So it's also really important for us to acknowledge that. Lastly, I was going to mention very briefly as well too, the importance of cervical screening in this population as well too. They too are important as well. However, this can also be quite uncomfortable for this group because we need to acknowledge barriers for comfort, barriers in regards to our gender dysphoria, and also potential past trauma as well too that may be in the background. So therefore, it's really important for us to invite them to bring a support person in if they prefer to do so. Using our person-centered language, having our gender-neutral words for our body parts, that may be also really handy to refer to those areas, but also as well too to actually enable a greater control for the person in regards to actually making sure you stay in good communication with the person throughout the procedure, the patient inserting the speculum themselves so they can control how far it actually goes and how it actually feels in there as well too. And if it's actually too much, having the actual having them actually remove it and looking at alternatives, like for example, our self-collection, which is now being promoted as well too in this realm. Another one as well too is to offer vaginal estrogen therapy for 2 weeks prior to the examination, especially for people who are actually trans men and still have a vagina or have a cervical area there to then be reviewed that way. So simple things like that can make a big difference. In regards to people who identify as being gay and bisexual men, we still have the same things here on this column, in the first left-hand column there. Plus also as well too, think about other aspects like if they don't want to be a parent, in regards to sperm donorship, surrogacy as well too. So because of course, as you know, men themselves don't have the parts there to carry a baby. So therefore, this can be actually a really important area to explore. At the present moment in Australia, there are different rules for different states and territory in Australia, but as a whole, commercial surrogacy is illegal in Australia still, and we're actually relying on altruistic surrogacy, which is actually legal, but it's not protective of intending partners. So therefore, that can be actually quite a tricky process as well too for people who are keen to have a baby locally here in Australia, and often people do actually go overseas, and they come and also actually at a greater risk of being exploited in the process as well too, either seeking this process locally or internationally. I know everyone actually likes to think about the importance of taking a good kind of sexual history to look at the different kind of considerations for people who identify as being gay or bisexual, because having insertive sexual practices, that does actually increase the risk of transferring germs from one person to another if the person who actually is the insertive partner already has an STI, or otherwise for the receptive partner to have an STI to pass it on to the insertive partner in that way. So therefore, we're going to dive into that in a moment as well too. So that's coming up in the next few slides. Also as well too, the importance of PrEP, I will mention again, which we will go into, but also our nuances as well too in our interesting kind of sexual practices as well too in this population. Things like your actual the use of recreational drugs at the same time as sex, known as chemsex, IV drug use, etc. That can also be a further level that complicates this level of STIs and sexual kind of transmission of diseases as well too. So definitely so, if we understand more about this area here, if we feel comfortable asking about that, of course, that will actually help to improve our understanding of what potential risk the person may be actually up against, and therefore be able to help to educate them and help them combat those risks in that way. Don't forget, I know everyone's been talking about the use of Gardasil to actually help to avoid having cervical cancer. But did you know that Gardasil is also important for men who have sex with men? And that's because it actually helps to reduce the occurrences of your of genital herpes around the anal area, which is the leading cause of anal cancer. So that's why it's important for both boys and girls now in the community to get Gardasil and get all the doses in there prior to them having their sexual debut. And if they have actually had sex prior to that point, of course, they do need an extra dose. Lastly, as well, to same as your bisexual and lesbian women as well too, gay and bisexual men also will benefit from having your Hep A vaccinations because of their anal oral transmission from their anal play. So it's important to us to remember that as well too.
So a question, Gordon.
Yes, please.
So with the extra Gardasil vaccine, if they've already had sex, does it apply to males and females? That's something I wasn't aware of.
That is actually currently one of the recommendations there, because because they do talk about having 3 doses there for a full course compared to only 2 if you were actually if you had your courses prior to your sexual debut.
Great, thank you.
No probs. Lastly, I was going to mention the importance of in the actual trans and non-binary or gender diverse community as well too, in regards to importance of gender identity and expression, gender affirmation, both in the social means as well as the medical sense, voice therapy, probably more important there for your men who actually, people who were born male but are transitioning to become female. So changing the way you actually speak, your intonation in there is really important for you to actually have more of a female-like voice or feminine voice. And also as well too, fertility and contraception as well too is still extremely important as well too. So I think it's important for us to remember who in the community may be helpful in that realm as well. So I think another big note here as well too is that, remember, it is not the job of our trans persons in the community to educate professionals on what they actually need. because for them it's so tiring to actually have to tell people what they need, what is important to them, and how to treat them. So being trans can lead a GP not being attentive to the physical health needs as well, because we can be, due to our own aversions, be scared to actually even talk about the actual area downstairs, and therefore be actually just going to skim across that and say, I'm too uncomfortable myself, I'm just not going to address it. But that can actually definitely put a person at much greater health risks. So being a supportive, inclusive GP to a trans person can make a huge difference to their longer-term physical and mental health outcomes. So I do encourage, for those of you who actually do have patients who are in this community, to actually do further education for yourself, to actually learn more about what we can do as doctors to look after this very vulnerable population. Now, I know that talking about trans and affirming things as well too, I think a lot of people do actually get very stressed in this area. So I thought I'll just touch on this very briefly here, since we're talking about this already. So what does that all mean, first of all? Because I think that's probably the tricky part there to get our heads around first. So it's important for us to remember that the sex is what you've been born into, and your gender is your expression of your actual of yourself as taking on the different gender roles in the community. And so for a person to actually undergo a process of transition, we are talking about going from being their birth gender to a different gender. And that can be in a binary sense, so for a male becoming female or female becoming male, or it can also be in a non-binary sense as well too, for a person who's more gender fluid in between, or could be actually identifying themselves as being genderless or gender neutral, or otherwise being just simply queer, and therefore in that actual fluid state where it's not exclusively masculine nor exclusively feminine. So a lot of the times this is actually the terms that a lot of our GPs in the community are struggling with at the present moment. But once you get past that, you can actually understand, okay, sure. So with their expression, what can be done to actually help to support that? And that's when we talk about our social transition, where we talk, and social affirmation as well too. That's when the person comes out to their peers that they are of a different gender to what they were born to, and being accepted by their peers as that gender. So that's when we talk about our social affirmation. Or we can talk about our medical affirmation. That's where we actually undergo a process of having our hormones to actually help to make that transition and express that phenotype as well too, to match their actual preferred gender. But then we can talk about also our surgical procedures as well too in the process there to actually confirm that as well. Furthermore, as well too, we do actually have our legal affirmation as well too. That's when we go through the process of actually legally changing our names, changing our gender, be it on our Medicare cards or our passports, our birth certificates, and all those kind of things comes into play. So that's what we talk about in the overall affirmation process. So therefore, for people who actually are saying, I'm going to a gender reveal party, guess what? They're actually using the wrong terms. It's actually not a gender reveal party. It should be a sex reveal party if you were talking about that. And that's such a really cute experience I had as well too, when I had an old lady actually recently tell me that, oh, I'm going to a sex party. No, not because in the actual sense of a sex party as such, but it was because it was a gender reveal party using the right terms in that way. So it's really cute. Anyway, if you were actually wanting to understand this process a bit more, I'm not saying that I want you to actually be engaging in this immediately, starting hormones for people, because it's actually a very tricky process in the whole scheme of things. But for us who actually may be picking up the care of people who are already on hormones, just to give you a bit of understanding, here's a few things to think about. If you have a young person or an older person keen to undergo a transition, what can we do to actually help to make that process a bit smoother for them and make the right referrals? So for blood test things wise, these are the common blood tests that we are often requested for before we make the referral. We look at our physical features as well too, our height, our weight, our blood pressure, and oh, sorry, that's meant to be saying waist circumference, not a weight circumference. And also if they are over the age of 40, having an ECG done as well too. And also to discuss fertility options as well too, because when we do start hormones, it does actually reduce the level of fertility. And once we have got those things in place as well too, then we can actually refer them to our 2 clinics in the area that we can refer to in our catchments. Up in the Newcastle area, we do have the Maple Leaf Clinic up in Hamilton East. That's more of a youth kind of service there, but they do look after people who are in the adolescence up to I think the age of 25 or 30 there. We can also actually refer them down to Sydney. Down in Annandale, we have the Gender Centre, and they've been doing this work for many, many years, and they look after people of all ages. So this is the common pathway we look at. So this is a person there requesting for testosterone, so a female transitioning to become male, and this is the common process we actually go through. So a bit of a complex process you can see there. And if they are a young person, as well as a child, the child themselves would need to have parental consent prior to onset of our hormonal use. And also as well too, to look at our clinical assessment to confirm the appropriateness by both a mental health clinician as well as a pediatrician or otherwise a pediatric endocrinologist. Ideally, to start the process before 10 or 2 stages of their pubertal development. And then we can, after all those things are in place, then we can actually consider our gender affirmation hormones. So for people who actually are in that process there but are running out of time, you can actually consider use of pubertal blockers to actually halt the process or slow down the process to buy them more time to then actually start their actual hormones in that way. And all of that is actually done by the gender clinic. So if you're talking about our feminizing hormones there, so we can kind of say female hormones that we have available to us in the community. And we can, if you're talking about your masculinizing hormones there, we're looking at our other hormones that we often come across as well too in the community in this realm. So therefore, there's nothing crazy, nothing special, but it's just simply kind of using these kind of hormones there to then actually turn off, in its essence, the person's own hormonal production to then actually express the different phenotypes as a result. So they actually undergo almost like a pubertal process there of actually developing the secondary characteristics based on the external exogenous use of hormones there. Of course, as I said before, I don't expect anyone here to actually start hormones themselves. I certainly don't myself. And even though I work in the kind of headspace and we do support a lot of gender diverse persons, especially people who are transitioning as well too, I always actually refer a person to their actual gender clinics, get them to actually do their work to confirm before you then actually am happy to then continue the care side by side with them and help to actually do that. So with that in mind as well too, so what are the kind of common kind of features to expect when we actually are starting these hormones? If we are using our hormonal blockers for people who are born male, transitioning to become female, these are the common features that we often do actually look out for when they are being used. If we are using our feminizing hormones once again, for a person who was born male, transitioning to become female, these are the common changes as well too that we actually would be expecting to see. And in those kind of time frames as well too. And then also as well too, we can also see here the masculinizing hormones as well too for people who are transitioning from female to male. One of the things I was going to mention here as well too, because we haven't mentioned this before, is that when you are actually using your masculinizing hormones for people who are born female, transitioning to become male, that actually causes a thickening of their vocal folds. So that's how they would get a deeper voice, and that's how boys get a deeper voice as men. So therefore, it's really important for us to also remember that that thickening of the vocal folds is a permanent change. So therefore, if they were to transition back because they no longer actually want to see themselves in that way, then of course they would actually likely need to undergo some voice coaching and voice therapy to actually help them adopt a more feminine way of speech to help them actually express themselves more fully in that feminine way. So yeah, I see a lot of messages coming through as well too in the chat there, talking about the andrology clinic department down in Concord, having the actual having Dr. Joe Measure up in the sexual health clinic up in Newcastle. Yes, definitely so. There are other options as well too. So that's definitely other options we can consider in this way. So but the thing is, if you are looking for more of a holistic kind of care there, often the gender centers themselves often do provide that in a better way. Yes, Julia.
I know there's also, if anyone's on the Facebook page GP Down Under, there's a branch for gender affirming treatments if you need any tips. But yeah, I agree, it's so complicated to initiate the treatment, but often they just need 1 or 2 appointments with, so the patient I've got with Joe Mashua, she's written some nice guidelines so I can continue the Reandrin treatment so the patient can come to me every 3 months for the injections. But
absolutely.
It can be, and sometimes the expectations of patients are tricky as well. Like I've had a patient that's had a 15-minute appointment, wants me to prescribe, gender affirming treatment there and then, and I was like, oh, it's more complicated than that.
Yeah, absolutely. And you know what, actually, because the current gold standard is to actually recommend for all persons who are going through this transition to actually have side-by-side concurrent psychology support throughout the whole process. Ideally, to actually have at least 6 months of intensive psychology support there to make sure that any other mental health conditions in the background are sorted first prior to them actually embarking on this journey, because it's actually a very stress-inducing journey there. There's a lot of rejection and acceptance. There's also actually a lot of different hormonal shifts, and therefore a lot of our moods and cells do go through a massive roller coaster ride, and therefore can be much more tricky than they actually realize. So definitely so. It's a very interesting area that we are exploring at the moment, but definitely a very important area to support a person in as well too. Cool. All right, I'm going to keep on moving because there's still a little more to go. I was just going to say, yep. So what about our actual our screening and also our ongoing care? What do we need to do in regards to our other kind of important tests to do afterwards? So these are common things we think about. So if you're looking at a person starting feminizing hormones, these are the important tests to continue to actually do at regular intervals to actually to look out for all these things, which can be potential complications from the actual medications. But also, too, for a person who may be actually having masculine hormones, you also do have these other tests on the side there. Now, I will apologize here right now. I do know that my last few slides have been very, very dense, and there have been lots of information there as well too. But I did it that way so you can actually come back to this in the future if you are actually having a patient who is actually undergoing this process of transitions. So you can come back to this to refer back to this. This is actually all a summary from the ASHM as well as the ACON course that's been released this year in March, looking at your transgender medicine and also LGBTIQA+ persons medicine in the community to help us improve our skills and knowledge as GPs in this area. So if you are interested in this area, or if you do have patients in this area, I do encourage you to actually find out more and do the course. It's a very simple, very easy course to actually do, and it's very straightforward, very interactive, and I'm sure you'll learn lots, as I did as well too. So, any quick questions before we dive into our final kind of section there? Yes, Chris.
Yeah, I was just thanks, Gordon. This is a really good overview. And one of the things I was just thinking there, we're talking about Tanner 2 staging, and this is an incredibly tricky medical legal area for GPs. Like I think,
absolutely.
I'm just thinking about consent, and if you've got someone in the 10 to 11-year-old age group, is there any support that you know of? I mean, I've had only a couple of patients that I've gone through this process with, and I've definitely referred them to specialists because it was definitely outside my scope. Yeah. But I just wondered is there support there? Because that's in terms of defining consent and informed consent in that age group. Are there any resources or people can help with that?
That's the reason why I would definitely say refer them out to a specialist team, and I really stress the word team as well too, not just simply a psychologist who actually is skilled in this area, but to actually have a team approach so that you can actually get the patient, their family support as well too, to be able to help them on this journey. And often as well too, it is a very interesting thing because how many things themselves are just simply a phase in a person's life there. Like for example, learning musical instruments, for example, they might want to play piano one day, guitar Takata next, how much of it actually is an ongoing kind of thing that they actually are really keen to do. And I think that actually helps us differentiate between who actually really does have this gender incongruence and gender dysphoria to actually underpinning the actual wants to actually transition in that way. But as GPs wise, we're really good at holding space to help to actually support a person until we get them to that further inputs. And I think it's important for us to continue to have that mindset as well too, that even though we may not always have all the answers, we can actually refer a person out to actually get someone who actually does have more answers than we do and be able to support them in their actual care, in their journey as well too.
And my only other question was, some of the new services that are available, are they free? Because when I went through with my patients, they had to see a private psychiatrist, and this was really difficult for this family.
Absolutely.
So are the new services free for the patient?
So the private psychiatrists themselves, often you get in faster, so that might be the only benefits. But for the Gender Clinic down in Sydney, as well as the Maple Leaf Clinic up in Newcastle, both services are free, because it's important that they actually offer that in that way. Both of them do actually have psychologists, have their actual their psychiatrist / pediatric endocrinologist / endocrinologist in that unit there, so therefore they're able to offer that kind of well-rounded kind of approach, not to mention social workers and support workers in there as well too.
Fantastic.
Yeah, cool. Sexual health. All right, let's dive into this. I know you are all experts in sexual health because we all ask about our sexual health in our patients on a regular basis, right? Yeah, I hope so. So it's important because if you look at the data here, I know it's 2018 data. It's a little bit late dated now, but it's actually the most recent data that we have available to us. You can see here that chlamydia is still one of the most notified diseases in the STI realm in Australia. Gonorrhea itself-wise, were actually going up in that short time between 2012 to 2017. And over the last 5 years, the rate of syphilis have actually increased as well too, and especially in Indigenous communities as well. But of course, having had a COVID lockdown, I wonder what happened during that time. It'll be interesting to see those stats when they are released. So STI screening side of things wise, I can't stress how great this tool is on the side here. So if you want to jump online and download the STI HIV prevention tool, this is absolutely gold. So if you have not actually got it already in your little file of goodies, make sure you do get it. Who do we screen? These are the people we look at, because these are all the people who actually have a greater level of risk. Now, when we're talking about our sexual health screening, we talk about our 5 Ps. But the thing though is that in this area here, it's very important to actually use a non-judgmental language and also to use a gender neutral language as well too. For people who actually may have a different or diverse way of engaging in their sexual practices, even talk about, so what bits do you have? What bits do your partners have? And how do you use them? Could be a very simple way of actually having absolutely no no connotations about names, issues in there, and having really objective, having a very professional way of actually talking about this area as well too. So inside the actual document there that I showed you before are these 2 pages on the inside talking about what to screen for, what tests to ask for, and who needs what tests, okay? And then also as well too, to then actually talk about their contact tracing as well too, if you do test positive for anything. In this area here, remember, based on what their sexual practices are, utilize that to help to make a more educated decision about what you test for. So for a person who may be transgender as well, going back to their birth gender would be actually the field you want to look at, but also as well to exploring and expanding that into the sexual practices to then consider, do we need to do a throat swab? Do we need to do an anal swab beyond their actual vaginal swabs? Those would be also helpful things to do. If you do have an STI, jump on the STI management website there. Very, very important to actually help you out with your actual treatment, and they do often change things in there to help to actually give you most up-to-date information. Contact tracing wise, of course, we do actually have all these resources there at our fingertips to help people with their contact tracing, and people can be anonymous as well too in the process too. I'm just going to dive into very briefly about PrEP, because PrEP came up recently in the actual college exams. And so yes, we as GPs in the community are expected to know how to do this. So let's look at it now. So PrEP itself is this little blue pill there, you can see, and it's part of the whole process of trying to eliminate HIV in the community. And this is the decision-making pathway there that I want you to actually use to help you in this area. So if you do have a person coming to yourself, asking to be started on PrEP, this document here, literally an A4 page, printed on both sides, will give you all the answers there. The most important thing, of course, is following, okay, what do we do at baseline, the test side of things wise, and if they actually have got all these things in the right order and no concerns there from their actual liver function test being normal, for example, then we can actually say, okay, follow the pathway. So we have already got the person here who actually is in the actual behavioral suitability realm. Then we can look at our clinical suitability. The testing have been done and okay, ready to go. Then you can decide to start PrEP. And then have our ongoing monitoring, which is then on the lower half of the next page there. This is our ongoing monitoring section here. So just literally following step by step. After the first 30 days, here's what we do. After the first 90 days, here's what we do. And every 90 days beyond that, that's what we do as well too. And the pill PrEP itself is actually structured that way as well too, that we actually have up to a 3-month amount every single time we prescribe it. So that it helps us actually make this easier for us to follow. So PrEP can be actually dosed in different ways. You can have it every single day having PrEP, or you can actually do what's called an on-demand PrEP, where you have 2 pills 2 to 24 hours prior to your sexual activity, and then continue on for 2 full days afterwards. Or you can actually even do your T's and S's, where you actually are dosing on the Tuesday, Thursday, Saturday, Sunday, because if you have at least 4 doses of PrEP per week, you actually have adequate protection. So this way here, you get about 95% protection, about low 90s protection for this way of using it here. And then for this way here, you're hovering around the actual low 90s to high 80s, etc. too. So yeah, so giving PrEP is actually quite simple. So support services wise, for people who actually identify as LGBTIQA+, we do have lots in the area. And so these are all the ones that I put together for us to actually access. We can all access in this area here on the Central Coast and also in the Greater Hunter area. I also want to show you as well too on the side here as well too different special days in the calendar of LGBTIQA+ persons. So therefore, if you wanted to actually be involved, find out more, these are really good things to look out for as well too. Yep. I was going to skip past this one here. And so I also want to end on this slide here saying that it is really important for us to look at this topic because diversity is a fact, equality is a choice, inclusion is an action, and belonging is the outcome. So if we can actually understand this community better, we can actually really make a big difference in the overall care of this minority group and be able to actually help to actually change all these statistics that we saw earlier, those terrible statistics that actually make lives difficult in this area here. So yeah, thank you.
Oh, fantastic, Gordon. Thank you. Just another question. So what about on the Central Coast, services on the Central Coast? Because obviously the I think that's in Newcastle. That's where I found it hard to navigate.
It is hard.
A young patient that can't really travel anywhere. They might want to start the journey, but even seeing psychologists, but parents aren't really on board.
Yep.
And I have noticed too, I think with our health pathways, I don't think it's got the details of on the house on it, so I had to then remember what the Newcastle password was to find those details.
Yeah.
So what do you suggest for Central Coast resources?
Yeah, it's actually really sad because we don't have the population at the present moment to actually have a gender centre on the Central Coast. So therefore, a lot of young people do travel up to Newcastle. The good thing about the Newcastle branch is that it is easy to access via public transport. So if you get the train to Hamilton, it's literally a few blocks from there. So I think about under 2K's walk from the actual station itself. So it's not too bad to get to by public transport. The one down in Annandale there in Sydney, you can actually jump on a bus. It's just between the Sydney Uni, just past that, it's a few more blocks beyond that. So it's on the Parramatta Road there, so it's not too hard to get to still. But yeah, definitely so. It's a tricky area. On the Central Coast wise, I know that there are a few different psychologists who actually are comfortable in this area and would do good work in this area as well too. I know here at Headspace, not here. Okay, at Headspace, oops. At Headspace there, we do actually offer a lot of support for people who actually do identify as gender diverse. And so our clinicians themselves are also quite skilled and very comfortable talking about this area and supporting young people in that way. For older people there, they often do have the means to travel a bit further, and so that can be another option as well too. I'm not sure if there may be actually, say, for example, telehealth options as well too. There are some psychologists and psychiatrists in Sydney who do offer that exclusively to their patients, and that may be another option there they can explore as well too.
Great. Any other final questions for Gordon before I talk about a few other things?
Sorry, I'm running out of time, aren't I?
Well, no, that was fantastic, Gordon. And yes, I'm sure you wouldn't mind us emailing you if we had more questions, would you?
That's fine. Yeah.
That's great. It's such a interesting topic, but challenging, especially when you have a patient that discloses, in a 15-minute appointment. That's where I'm like, oh, where do I start? This will help us navigate. And so thank you.
Thank you.
Quickly, just a reminder for the GenPED conference, which is on the 29th to the 10th. So if you're interested, Jenny's put the link in the chat box. Also, in 2 weeks' time, Ian's doing his interactive talk on asthma management. So Ian, did you want to have a quick chat about that? About you're being very high tech with your Microsoft Whiteboard. So tell us more, Ian.
Oh, yes. Well, we're going to talk asthma management. Everybody knows about asthma and all that sort of thing, but moving on to the next level of how to manage the asthma. And what I wanted to do was, as we did last time, use the whiteboard and show you the drawings and diagrams that I actually use with patients, so that not hopefully only learn about asthma, but how to do it. And it might be fun. I don't know, there's the experiment could be a disaster. But if people are able to download Whiteboard, that's an accessory to the Microsoft Teams, then you can all do drawings as well with me. And we can compare people's drawings. We could even have a prize for best asthma drawing at the end of the session. You'll be pleased to know that I can actually take back control if some of the drawings get a bit spicy. But anyway, that might be fun for the next talk on asthma self-management.
Oh, that sounds like a lot of fun. We look forward to that, Ian. No,
Okay.
great. Thanks, everyone. And thank you again so much, Gordon. And we'll see you in 2 weeks' time. And don't forget to fill out your evaluation as well. Awesome.
Cool. Thank you so much.
Thanks so much, everyone. Only 3 more vertical integrations left until the end of the year.
Beautiful.
Bye-bye.
Bye. Thank you.